Dr. Salman needs no introduction. He is like one of the top neurosurgeons of Pakistan. He has a special interest in spine surgery, minimally invasive spine surgery. He's the president of the Pakistan Society of Neurosurgeon, president of the Middle Eastern Society of Spine, as well as the chief surgeon at Liaquat National Hospital, Pakistan. He is going to be presenting the learning curve in the minimally invasive spine surgery. Dr. Salman, please start sharing your screen.
Okay, guys, can you see this clearly?
Yes, we do.
Yes.
All right, great. So thank you, Neela, and thanks ACNS for especially Women in Neurosurgery for organizing this. It's wonderful to be here. I'm sorry, I thought I was another hour later, but it's okay, it's fine. I just woke up 20 minutes ago, so I was having an afternoon nap. Anyway, so let's start. I think MIS is now a big deal these days. And nearly everybody is trying to catch on into it. We know that anything that comes in new has got a initial period when there is all happy period and everybody is doing it big time, starting new things. But slowly and gradually, we realize there are some things which we should not put our hands into, and there are some things which, yes, it's possible that you're able to do new things in a better way. So I'm going to be talking about the learning curve for MIS surgery. Well, the spine treatment milestones are basically back in '84 when Dick and Kluger got together and described more than 30 years ago the design and the modern pedicle screws. And Megrel joined them from Switzerland, so all of them were pioneers in pedicle screw surgery. And, you know, history of MIS really can't be completed without Foley and Smith beginning the modern era of MIS when they described their tubular microendoscopic discectomy in 1997. And now, slowly and gradually, it's been routinely applied to a spectrum of degenerative spinal conditions. Now, herniated discs are routinely done, stenosis is routinely done this way, prosthesis instability, and recently deformity and other formats are also addressed via MIS. So the concept of any surgery, and MIS surgery is performing surgery. We need to access a surgical target deep inside the body. There is a surgical path, approach is created and is approached, surgery is performed, and the surgical path is closed. Despite following normal anatomical paths, surgeons destroy normal and functional tissues. We know this. And we leave scar behind, which could be functionally inactive. So footprints are left behind, just like, you know, on beaches, sometimes we leave some of the footprints behind. Surgery concept is basic, again, same, smallest footprint. So, you know, on one side, as you were showing earlier, we could have something like this. On the other side, you could have something completely open. Still, there are indications for open surgery, just like, you know, I was doing a surgery yesterday, as somebody who's had 3 previous surgeries, infection, and everything is mocked up. There's a lot of bony extra formation, and all that needs to be decompressed appropriately. And if you've got multiple levels, then it's not possible to do all that MIS. So there are indications for open surgery still there. MIS is keyhole surgery. What you're doing is trying to use natural planes, so leaving significantly less fingerprints if at all possible. Why MIS? This debate has been going on a long time, but we know that there's minimal neuroretraction, there's contralateral anatomy, could be preserved if you're doing one side, shorter hospital stay. We know this is proven, minimal postoperative pain, and earlier return to normal activity has been shown and confirmed. Economic benefits in some ways, while we are reducing infection and obviously pain, early recovery could also play a role. Having said that, if you have less revisions as well, then obviously then economically it could be beneficial as well. So what is learning curve? The concept of learning curve was originally introduced back in 1936 by Wright in the aircraft manufacturing. And he described a basic theory for costing the repetitive production of airplane assemblies. The term was introduced in medicine in the 80s, mainly after the advent of minimally invasive surgery, and has been a big deal for us over this time. So can we define it? A simplistic, reproducible method of defining could be time taken or number of procedures an average surgeon needs to be able to perform a procedure independently with a reasonable outcome. Reasonable outcome means the outcome may be same as open surgery. And it's very difficult to identify an average surgeon. Somebody could be a brilliant open surgeon, but minimally invasive. They may not comprehend what's hiding behind and if he's trying to do things which are hidden. So what are the factors that affect learning curve? The learning curve may depend on manual dexterity of the individual surgeons, background knowledge, anatomy. If you don't have that, you can't be a surgeon. The experience of supporting surgical teams. So you may introduce MIS, but your surgical team is unaware of it. You're going to have a lot of problems. Frequency of procedures performed. So the more you perform, the better it is. And new technology does not always apply to all cases. So it's very, very important for us to know. Recently, Roger Hartle, who's here in this session as well, has suggested and proposed that we should try to do every case MIS, even you're talking about starting from tumors to discs to anything. And if you do that continuously, obviously your colleagues and the people around you in the theaters, they all could improve the way things are done, and you yourself could, your learning curve is not there at all, and you're able to do things that normally you are not able to do. So they suggested we should do more and more of these. So training on inanimate trainers and animal tissue has been shown to facilitate the process of learning, and now we do this routinely. In fact, with our World Spinal Column Society, we perform about 8 to 10 workshops involving animals as well as inanimate trainers during this time. And all this simulation has come into play during this time as well. The presence of structured training schemes and mentoring are very important factors, and they should not be forgotten. Slope of a learning curve depend on the nature of the procedure. So learning curve for MIS is longer than for open procedure. Well, there have been multiple studies, and studies have shown that when inexperienced subjects are given equal training in laparoscopy and open surgery, the overall skill acquired were similar in both methods. And recently it's been shown in MI spine as well that even inexperienced surgeons were able to do things. And by inexperience, I do not mean that that was their first case. Up to 30 to 40 cases, if they've seen and done, they were able to perform with some kind of reasonable result as good as MIS. So complication rates are inversely proportional to the volume of workload. So you may be a brilliant surgeon, but if you're doing 5 surgeries a month versus somebody who's doing 20 surgeries a month, obviously your outcome and your know-how and complication tackling will be completely different. So we know this, and this has been shown in other specialties as well. So as the surgeons become more experienced, there is a trend also to take on more challenging cases, which could again affect the outcome in an adverse manner. So you may be doing excellent simple MIS cases, but when you're trying to do new things and getting your colleagues to push and do stuff which is complicated and difficult even in open surgeries, then obviously you could cause more adverse effects. So limitations and contribution that may contribute to a steep learning curve could be if you don't know your anatomical landmarks. So you may have a person who understands everything very well in an open surgery, but in closed surgery is not aware of the landmarks on the image intensifier and do not understand that. So mystery attributed complications during the microendoscopic discectomy learning curve to unfamiliarity with endoscopic image orientation and suboptimal approach to the surgical target. Injury to neurological structures were shown in initial phase in lots of studies. Multiple durotomies were shown in the initial phase. And we know the reason was that people were not aware what they were seeing on the image was really a dura and not a structure that they could remove. Wrong level procedures are done, and many times MIS are done. But you've got a lot of imaging going on, but as long as it's the same basic principle are going to apply, and again, your understanding of your anatomy and understanding of your images are very, very important before you start any surgery. So you may have done 1,000 cases, but if you're doing 20 a day, and I know people who do perform lots of surgeries a day, and in their cases, obviously, now and again, they come across a problem when they're not thinking in the line of how to avoid complications for each and every case. And then there is many a times when we can remove a facet joint structure, not knowing this is facet joint and thinking it's abnormal tissue. So all this has been contributed with various studies. So the key step in overcoming the MIS learning curve is ideal entry point if you're talking about some kind of tubular dilator that we are putting in, and to have the trajectory in the line of the surgical approach. For example, if you're doing endoscopic discectomy, you need to be coming really perpendicular to the disc, or wherever the disc is coming out. The sequestra is inferiorly, you come down inferiorly. If you're thinking medially, you come to medially. So, you adjust yourself accordingly. So all that can be overcome when we know the anatomy and the pathology of the patient beforehand. So Tall and Hai asserts that there's a correlation between the initial placement of the tubular dilator during the MIS-TLIF approach to prevent intraoperative readjustments. And we know that we have all been through this, that many times you come in, one of your junior has put in a tubular dilator and it's not in the place where you want it to be. And you can get away with it, but sometimes you end up changing a bit. It's like, I was doing a cervical disc a couple of weeks ago, and one of our chiefs had opened up and really had not thought about where the incision was going, and had just gone on the anatomical landmarks that he thought were right. And he was right on anatomical landmarks, but it was much easier if he would use the image intensifier and make life easier for himself. So I ended up having another parallel incision, but you can do that many a times in MIS as well. It's possible. So how do we measure this learning curve that we are talking about? So it could be patient's outcome or a clinical process or task efficiency. So common patient's outcome parameters are, incidental incidence of the complications and survival. So if you do a procedure, the number of complications you're going to have, and when you come to a plateau where you say that your number of complications or survival outcome has come to a place where you're as same as your open surgery, then you say that's your plateau and that's your learning curve. So if you look at statistical analysis, it's much, much more complicated than just looking at the complications and survival outcome. Hence, many a times we use operating time, the time that we are taking to do open surgery versus MIS surgery. And if you can repetitively have the same time with doing minimally invasive surgery. And then period of hospitalization tells majority of the story, that, how long did the patient stay? Because really these patients, when you're doing MIS, have less pain than open surgery and less discomfort and mobilized early. So if they're staying longer, then definitely there's something that we're doing wrong. So what are the pitfalls of this measurement? There is no ideal measurement of learning curve. Various proxies are used for measuring the learning curve process. While we may agree on how to measure the learning curve, we cannot say how we should compare individuals' progress, particularly when we are dealing with real patients and having real surgeons. So it's very difficult because every surgeon is different. So you may have a performance which could go up like that, an experience which is coming like that. And you could come to a asymptote somewhere here on point C, and that's where you'd like yourself to be before you're comfortable that your resident or SR or chief is able to do all that you want to do open surgery and have equally good results without even supervision. Damaged nerves was a big deal. So Nancy Epstein wrote this editorial in Surgical Neurology International and did a review and said that smaller incisions don't necessarily mean better outcome if the surgeon is not familiar with anatomy and exposure. And there is, there is no magic about it. Obviously, this is very, very important basics people should understand. Obviously, MIS has caused increased radiation exposure. Recent studies suggest increased radiation with minimally invasive techniques. And we have shown recently in many studies. So there's a big study out from Cleveland showing that they had patients who were having huge dose of radiation, and the junior surgeons having a huge dose. For example, one of the case that Richard Assaker in Lille in France showed had 800 shots of radiation while having a single level MIS-TLIF by junior surgeons. So it's possible, but we do need to understand there'll be high risk of causing serious issues later on to your eyes, your thyroid, and cancer-related issues. So all that is important. And This also comes into play, that how can we avoid all this radiation while we are doing MI surgery, and where is the learning curve? So, you know, minimal amount, number of shots that you need, that's also comes into learning curve. Then how many shots are you requiring for a single level MIST lift kind of thing? So you need to understand that, you know, your radiation dose is 2 to 3 times the dose here where exactly your X-ray tube is. So if you're standing over here, you would cause serious problems to yourself. The dose is about 1 over here and goes half up here. And so this is the emission area. So you need to understand that standing here may not be the best thing. And if your image is like this, and if you're standing here, that may not be the best thing as well. So all this also comes from understanding the learning curve for reducing the radiation. So there's attention to protection. It's very important. So your goggles, your gloves. Nowadays, we are not using the radiation protecting gloves as well. We have realized that we were actually accumulating radiation into our gloves. And while we were doing that, we were causing more radiation to our hands than anything else. And so since then, gloves have gone out the window, and we are trying to stay away from radiation as much as possible. So we use a dosimeter routinely. We use stable shields. We use leaded plastic barriers. Nowadays, we try to use double shields for our double shields. By I mean, you have a vest and you have a skirt underneath. And the skirt may look very nice on men, but you know, it's in order to avoid radiation, that may be a good way to go, because then it doesn't cause problem with the weight at all. So this understanding that where you're going to stand is very, very important. So you need to try to stand away from X-ray tubes, and that goes for your assistant, that goes for your scrub nurse, all the other people who are there in theater. They all need to avoid that, because you know that all is part of your learning curve, your initial time that you want to be away from this X-ray tube. So you want this distance to be much bigger than the distance on the top. So X-ray tube should be as far down as possible, and try to keep it down. And if you have to stand, you know, try to stand at least 3 feet away from the X-ray tube. So we do understand this inverse square law, which is scattering around the patient. So if you stand about 1 meter away from the radiation, then dose comes to 1. Whereas if you go down to 2 meters, it drops down by 1/4. And if you go down to 3 meters, it actually drops by 1/9. So actually, it's an exponential inversely proportion in which the radiation goes down. So you need to understand all these. So these X-ray source distance keeps you away from the dose by a factor of 4. So you need to try to move as back as possible, if at all possible. So what is a average learning curve? Learning curve, MIST lift. So this is a friend of mine, Paulo Pereira from Portugal, and he came out, they correlated with a steep learning curve. That's what they call. I'm not sure if we can call steep, because by steep we mean which is taking much longer. It was taking about approximately 40 cases before they were able to have a uniform result. So half of the improvement in the learning curve can be achieved after 12 cases. When 90% the expert's proficiency level is achieved around 40 cases. So if you've done open surgeries, you understand all that, then it's much easier for you to understand the concept. And so, you know, before falling down, you could have brilliant results. So this is from SNI 2017. And obviously this is the study from Silva, in which they showed that, you know, this overall complication was up to 12%. And there was more frequent dural tears than 5%, and complications were about 33 and 20. And they showed in their first 100 cases, and followed by the rest of the cases. And then they kept showing that the results continued to improve and then plateaued afterwards. So the learning curve, there's a negative exponential. That's what they showed, that, you know, obviously there is a curve that goes down in the reverse direction, showing that slowly and gradually the number of cases that you require to have corrected operative time keeps on plateauing once you have done up to 40 cases. So 90% of the learning milestones is up to 40 cases. When you look at microendoscopic discectomy for lumbar disc herniation, and looking at 873 cases. So if you look at this, they took early group 220 cases and late group up to 650 cases. And you can see that the operative time improved a lot. and blood loss really became half during that time. So when you're doing this and you're trying to do surgeries through a keyhole, you may not be able to have a better control in the initial phase. But when you understand the concept of MIS, everything becomes easier and simpler in these patients, and even VAS was better in this group. So comparison of minimally invasive versus open standard microscopic discectomy. So this was a randomized controlled trial that was published in European Journal of Neurosurgery. And they clearly showed that and when this was done in experience center versus a transfer center, the results were completely different and showed that eventually the learning curve got caught on to just like a referral index center. So operative results and learning curve, microscopic assisted tubular surgery for 1 or 2 level discectomies and laminectomies. So this is way back into 2008. And they showed that we're doing 1 level and 2 level, their duration, their outcome, their complications, time period, patient's outcome, everything improved in their second set of phases. So you can see that if you're in learning curve kept going down in all these, and they were able to come to a plateau slowly. So failure, we know we are built in to make mistakes. There is a code of error in us, and failure is inevitable. But it's important that you understand anything that before you start to do, what others have done, what they have learned from that. So the comparison of MRS versus open TLIF with regards to clinical improvement, fusion rate, and incidence of major complications. This is European Spine Journal, 2015. They got hold of 14 studies together with 12 months follow-up involving MIS TLIF versus open TLIF. They had similar fusion and complication rates. However, higher revision readmission rates were attributed to deep learning curve. They have observed that MIS surgeon requires extensive training, experience is necessary, otherwise MIS TLIF may yield unsatisfactory results upon patients. So some studies have documented comparable long-term outcome for open versus MIS spinal surgery. So is the learning curve really worth it? This has been discussed many a times, and we know that if you look at this, this is the Nancy Epstein, only 4 patients are included in this, and later on, they had a study with 200 cases showing much better results in that. So complication associated with initial learning curve of MIS, this is way back a study during the 2000s, and they showed the total complication rate was 11%, and the most common complication attributed to MIS was durotomy, while for fusions, complications including implant imposition, malposition, instrument-related neural injuries, and non-union were features. Many times when you're doing MIS TLIF, you're trying to compress, and your compression may not be as good in the initial phase, but now with modern gadgets, you're able to do that. So once you know which instruments to use, where to go about, obviously your results could get better and better. So if for looking at MIS, for MIS surgery, 20 to 30 cases were required for learning curve of TLIF, MIS pedicle screw, and MIS cervical surgery. Several other studies have described learning curve for MIS, describing between 10 to 44 cases under supervision. So in conclusion, surgical aptitude, manual dexterity of the trainee, and structural training are important factors in reducing the learning curve. Now what's happened is, with MIS being there from very beginning, unlike when we started out, obviously we didn't have MIS. And so we had to learn all this with various workshops, going to colleagues, learning different stuff, reading a lot. Nowadays, as part of residency program, the training of MIS has been there. So their understanding of open as well as MIS surgery is much better than for people who started doing MIS in the earlier period. And there was this resistance as well. Would they like to do this, or shall they continue with the better results that they were having with open surgery? But they really, it is worth it, because the more surgeries that you're going to do with MIS, the better you're going to become, and the better results you're going to have. And we know that it's excellent for the patients themselves. So facilities for training and practical practice of surgical techniques have an enormous impact. And we understand that as part of many spinal societies, and more workshops and forums out there. And so you've got different types of gadgets that you can learn on. And they have a huge impact on the learning curve. It's been shown, and we have also shown that. And training with trainers and inanimate trainers, animal tissue is vital to improve the result. It is worth it. Should I be moving from my traditional procedure with fewer complications to relatively new procedure with higher complications during the early cases and increase operating time? And I would say yes. You need to understand this, that you could have a plan, something like this, that you want to go from point A to point B. Dr. Anila understands this very well. She does a lot of cycling. And here we are in reality. Obviously, you could have a scenario like that where you could have fire, you could have water on the way, there was snow. Well, you know, so there is something interesting while you're doing your surgery every day. And you need to be ready for that. So just enjoy this clip. So this is basically, you need to understand, you need to go into the horse from the side and not from the back. So learning curve factors, there are surgeons factors, disease factors, training factors, and hospital factors. On all these run into play. Thank you very much. Thanks for having me.